Ladies and gentlemen, we move ahead with the next leg of the orations. Coming up next is the WCCPCI 2012 Dr. S.K. Parashar oration. This year, this oration is being conferred on Professor I.P. Vijay Lakshmi from Bangalore. May I invite Organizing Chairman Dr. H.K. Chopra, Chairman Scientific Committee Colonel S.K. Parashar, and along with them would be Drs. K.K. Agarwal, Anita Saxena, Hansa Govil, and U. Satyanarayana. We will have a total time of 18 minutes, 15 minutes for the delivery of the oration, and 3 minutes for the oration protocols. May I request Dr. Chopra and Colonel Parashar to please take over. Thank you.
Ladies and gentlemen, going to be a very important session, and Hanumanta Reddy is a very eminent person in all of our conferences. The subject he is going to cover is hypertrophic cardiomyopathy. May I request Dr. Hanumanta Reddy to please come forward and have his presentation. Hanumanta Reddy, sir.
Thank you very much, sir. Thank you. This is one of the outstanding conferences I ever attended, and it's a super conference. The gentlemen who organized this must be supermen. I think they are superhuman beings. We thank Dr. Nanda, Dr. Chopra, Dr. Satish Gupta, Dr. Rakesh Gupta, and Dr. Parashar. So they have done an outstanding job. I enjoyed it. I have learned a lot. We have limited times in the next few minutes. I thank the chairman, the organizers, for giving me the opportunity to present a few facts about hypertrophic cardiomyopathy. This is a God-given disease. And ladies and gentlemen, let me tell you, in the last 3 days, we have learned a lot about man-made disease. This is a God-made. So you're born with this disease. So it's not very common, but when you have it, you need to know before you start exercising. I know we have told you exercise is good for you, but before you exercise, sometimes you need to get a checkup, echo checkup, or maybe a physical examination by your doctor. You may have this condition. If you have this condition, hypertrophic cardiomyopathy, the large, thick heart you are born with, if you're exercising, you're running or bicycling or whatever you're doing, you can drop dead. So this you have to get echo done. So the free echo camp runs very well. I mean, really, it's very, very relevant to this. So I have a case of a young man in States who actually came to me. He was a 27-year-old gentleman. He had a syncopal episode while playing basketball with his child. And the patient had no prior medical history, and the physical examination was remarkable for systolic ejection murmur. This is echo, very thick heart here, so you can thick heart muscle. And in the different views here, thick heart muscle he was born with. He didn't know that. He passed out. That's the first time he found out. This is the angiogram. We don't need to do angiogram, but we did this. You can see this, the cavity closes completely, blocks up completely. And then he had surgery done. The excess muscle has been taken out of the Mayo Clinic. Then after that, the echocardiogram. So another gentleman, 39-year-old man, with no medical problems, and he came for exercise screening. Like the echo camp they did, he had echo done, and his physical examination actually was normal. EKG showed some LVH, and the echocardiogram showed the following here. The EKG is very abnormal. He didn't know he had this problem. He just came for a checkup. So that's you see the thick heart muscle here, very thick heart muscle here. So this that he's born with that. So that's a killer if you don't know you have it. And this is a CAT scan, CT angio of this heart here, thick heart muscle. And of course, echocardiogram shows increased the flow, basically systolic flow here, the dagger-shaped flow, and Valsalva maneuver and amyl nitrate makes it worse. See, it's not moving right here. Okay. Now, of course, you have a diastolic dysfunction, prominent A wave here on the echocardiogram, as you. And so we told you this condition can kill you without you knowing that it's going to kill you. In 2004, for example, we have a lot of news in the United States, the newspapers, killer that claims young lives each week in a marathon running, and parents call for action because of this. Some of the children died, and teenager collapsed during dancing with friends. Unexpected tragedies. So every year, some people die because they didn't know they have this condition. So this hypertrophic cardiomyopathy, thick heart muscle, was described by British patients at the beginning. They had no sophisticated echocardiogram, simple M-mode echocardiogram. Massive hypertrophy of the heart was found. And the first clinical diagnosis was described by Dr. Braunwald. Everybody knows him. And WHO defined as left ventricular hypertrophy, right ventricle also hypertrophied. But most of these patients have asymmetric septal hypertrophy. Septum is more hypertrophied than the free wall, but also there are other varieties. You define hypertrophic cardiomyopathy in the absence of high blood pressure. Of course, they don't have high blood pressure. They have no aortic stenosis. And left ventricular cavity is small, and the septum is hypertrophied. And there are varieties of this condition, as you can see. Subaortic stenosis, so-called HOCM. Here in this, the septum is more hypertrophied than the free wall, and you have a mid-ventricular hypertrophy here. And the apical hypertrophic cardiomyopathy, the Japanese variety, and you have diffuse hypertrophic cardiomyopathy. These are the varieties. And of course, one of my former fellows, Dr. Shirani, published his paper on JCC. The interventricular septum is quite thick and compared to free wall, and myocyte hypertrophy, there's a fibrosis. The interstitium has increased amount of fibroblasts and fibrin tissue, smaller than normal intramural coronary arteries, and histopathology is very characteristic. The myocyte disarray here, the muscles are in disarray as compared to the normal pattern of the muscle cells. And of course, hypertrophic cardiomyopathy, various degrees of hypertrophy, various degrees of obstruction, it doesn't come in one form or shape. We already demonstrated that. And it also has, it presents different ages. Young people, middle-aged people, sometimes you're 60 before you get this. I mean, you know you have it. And mortality is also different. And of course, I'm not going into details because of time limitation here. In the sarcomere, there's normal sarcomere. You have actin, troponin, myosin. And the myosin is the one which undergoes change. It's a genetic problem. It's a genetic disease, autosomal dominant. Beta myosin heavy chain has alteration. And of course, in isolated cardiomyocytes, if you isolate cardiomyocytes where the hypertrophied, you see, compared to the normal cardiomyocyte here, and similarly in eccentric, in a different way, dilated cardiomyopathy, your myocyte is elongated as opposed to thick cardiomyocyte. I'm not going to bog you down with these details of signaling pathways. In these people, what happens is you have a decreased cardiac output, and your angiotensin 2 and endothelin 1 increase, and they increase the basic pathologic mechanisms such as increased intracellular calcium via calmadulin, and also you have what happens is you have a hypertrophy, apoptotic pathways by killer cells are activated. You have increased calcium, decreased contraction, and also apoptosis, and it leads to hypertrophy. So this is a basic mechanism there. And of course, clinical presentation, everybody knows they can present with dyspnea, chest pain, syncope, presyncope, and of course, leading cause of death in competitive athletes. They can be asymptomatic, they can have angina, they can have syncope, dyspnea, sudden death. The first presentation can be sudden death, and then you have a problem. We have basic components in one variety here, asymmetric septal hypertrophy right here, with the so-called ASH, you're taught in the textbooks. We have the other one, systolic anterior mitral valve prolapse, causing mitral regurgitation, and ASH, hypertrophy and obstruction, outflow obstruction. See, this slide is not moving here. But anyway, compared to regarding treatment, the treatment when you see these patients, even though they are asymptomatic, you need to, of course, put them on. Thank you very much. Physical exam is characteristic. You have heart systolic ejection murmur. It gets worse when you have Valsalva. When you have, of course, when you give amine nitrates, it's very, very characteristic. And one cannot miss this. And of course, depending on there are some factors which decide who is going to die. Severe hypertrophy is one of the risk factors for sudden death. Young men, the younger men, like 14 years of age, if you have a syncope, non-systemic ventricular tachycardia, those are the factors which might predict your death. So those are the things we look for. Of course, asymmetric hypertrophy, I'll just skip this. Cardiac catheterization is not necessary in these patients because echocardiogram is very characteristic. And if you do cardiac catheterization, you see a big gradient between the left ventricle and the aorta, so-called Brockenborough response. We don't need to do that. Natural history we talked about. Young people, they can be asymptomatic. They may present with syncope. They may present with symptoms. Yearly mortality is up 3% a year. If you have a tachycardia, non-systemic ventricular tachycardia, it increases to 8%. And of course, the factors predispose you to sudden death or younger age. At the age of 14, if you present with this condition, you're likely to die. Male sex, family history of sudden death. You need to screen the whole family for this condition. This is autosomal dominant. You have a history of syncope, you're predisposed to death. And you have a so-called arginine mutation, genetic mutation, and that is bad. And when you exercise this patient, if you develop low blood pressure, hypotension, they're likely to die too. So Now, the mutation we talked about, if you have arginine to glutamine mutation, they are more predisposed to death as compared to leucine to valine and glycine to glutamine. So thus we can identify. We talked about the arginine mutation, they have higher death rate here, C and D as compared to A and B. Then risk factors for sudden death we all talked about, and then management. How do you manage these patients? Family history is extremely important. If your sudden death in the family is there, we need to consider ICD. We have talked about in the last 3 days. And we have to exercise these patients to determine the presence of so-called left ventricular gradient. If it's more than 50, they are also highly likely to die. And the counseling regarding strenuous exercise, we talked about exercise. Again, I reiterate, these patients, they can die from strenuous exercise. So too much exercise is bad for you. We also developed so-called PDPDs, cardiomyopathy, the Greek runner who died after 150 miles. So we have to be careful when we talk about exercise. You start slow. And the instructions for prophylaxis against infective endocarditis because they have mitral regurgitation. And first-degree family members should be periodically screened and they should be followed. And genetic testing is important. Unfortunately, this condition is not very common, so there are no randomized clinical trials for medical treatment. So based on physiology, we prescribe negative inotropic agents singly or in combination. This is a very busy slide, but I'll just go over important points. The first line of drug, as you know, is the beta blocker. And then if you have volume overload, if you have a little bit of edema, these patients, you don't want to use diuretics. If you use diuretics, you have to be really, really careful. If they do not tolerate beta blockers, you give them calcium channel blockers. And of course, if they still have problems with chest pain, dyspnea, you add disopyramide. And of course, you risk stratify them. If they have a sudden death syncope, they need ICDs. If they have, we talked about risk factors, the high risk patients, more than one risk factor, they need ICDs to prevent sudden death. And exercise recommendation. On my patients, I told them, please not to play basketball, no competitive sports. They have to go slow and at their own time. The most important thing is follow the family members. Beta blockers we talked about, it is a clinical improvement occurs in more than 50% of the patients. It decreases excessive contraction, prolongs diastolic filling time, increases coronary perfusion. They don't tolerate beta blockers, calcium channel blockers, and non-pharmacological therapy. If they do not tolerate drugs, what do you do? If they remain symptomatic, such as dyspnea, angina, despite maximal medical therapy, and if you provoke outflow gradient, so what do you do then? We need to consider so-called septal myomectomy. Many people in the world do it. I'm sure they do it in India. Mortality rate is less than 1 to 2%. Some complications could occur, complete heart block. They may end up needing pacemaker. They may develop a septal rupture, aortic regurgitation, but then are very uncommon. My patient had septal myomectomy. He's doing fine now. And of course, if you don't want to do surgery, you can do alcohol septal ablation. As you know, you can put a balloon in the septal perforator here, and then right here, and inject alcohol. And after the alcohol injection, you can see the septum. It was thick septum here that became thinner. So that works very well too. And of course, then dual chamber pacemaker, some people used it. NIH has a protocol where we put a pacemaker by negative remodeling. Heart got better, but it was not very dramatic, so they abandoned this modality of therapy. I'm not recommending this. ICDs, we should have low threshold for ICDs in these patients because they are a sudden death risk. Then the risk factors we talked about, family history of sudden death, unexplained syncope, LV wall thickness more than 30 millimeters, abnormal exercise, hypotension, non-sustained ventricular tachycardia. And if some patients, I had a family of patients, they had hypertrophic cardiomyopathy for 10 years and then they developed a systolic dysfunction. Then we put them on our transplantation list, and one person got transplantation, the other person while waiting for transplantation died. So-called burnt out hypertrophic cardiomyopathy. They are the ones we need to consider either artificial heart or heart transplantation. And then a couple of caveats in the last couple of minutes. I'll tell you, these patients, Dr. Chopra already pointed out in another context, strenuous exercise such as isometric, like lifting weights, that can be dangerous in these patients. They may develop hemodynamic collapse and sudden arrhythmia can develop. And also, you don't want to let them get dehydrated. They need to drink a lot of water. Dehydration can make it really, really worse. And the other thing, my patient, the accountant, he had septal myectomy, came back from Mayo Clinic. After 2 years, he developed atrial fibrillation. And atrial fibrillation is very bad for these people. They lose atrial kick, and then you need to convert them and, of course, ablate atrial fibrillation. You don't want, if they develop hypotension, you don't want to give dobutamine. You want to give phenylephrine, vasoconstrictors and fluids. And in summary, hypertrophic cardiomyopathy is an example of genetic autosomal dominant cardiac disease. It has a characteristic structural abnormalities, hemodynamic abnormalities, physical exam findings are characteristic. You can't miss it. We had made dramatic advances in the last 2 decades, and it is a favorite topic in the medical exams for the medical students. But thank you very much for Chairman and ladies and gentlemen. Appreciate it.
Well, Hanuman, what I presented yesterday in my talk, there was a paper in this ACC 2012,
Yes, sir.
in which they found that there was a significant increase in a supine exercise echo after lunch as compared to a supine fasting and standing this, and they found a significant increased gradients.
Oh.
So that was presented in ACC 12. From 30, the gradients went up to 90 when an upright exercise was done after postprandial. So they suggested
Sunil?
that any complaint
Mike.
of HOCM patients after lunch or after meals should not be overlooked, and number 2, it should be avoided. They should avoid doing an exercise after this. That was present in 2012, they presented.
Oh, thank you very much, sir.
Very,
Appreciate
very
it very
nice
much.
comment by Dr. Parashar. Sonia, she wanted to say something?
Very nice talk. I congratulate you.
Louder, can't hear you.
Little louder.
I did not sleep all night preparing this lecture, but anyway, I wanted to comment that I'm responsible for hypertrophic cardiomyopathy patients in Egypt, and in some patients, you did not mention at all cryoablation as a mode of treatment, and it was published by an Indian doctor and in Germany, and we sent patients to him to do pediatric patients, so I just wanted to mention this. And I wanted to mention also that many patients, we screened the family and we discovered that accidentally that the father has lived his life with hypertrophic cardiomyopathy without coming to us as a patient, and even grandfathers. We traced them up to grandfathers. And it's such an interesting thing that it runs so much in families, and I would have loved to see the Indian publications on this.
I think it's a very important issue you raised. We see a lot of patients of hypertrophic cardiomyopathy, and I think, as you mentioned, is very commonly practiced in India, whether it's an alcohol putting in or by radiofrequency ablation. A lot of data and lot of presentations we have in our ECHO conference. We are also having a meeting in Chennai, and I'm sure a lot of discussion is going to take place there as well as in our national. The point which was raised by Dr. Parashar was very, very pertinent, that any patient who has got a hypertrophic cardiomyopathy, if he has a significant alveolar gradient in the lying position, if you just make him stand, just change the posture itself may cause a sudden rise of gradient. And as he mentioned, on the top of it, if you make him exercise in a standing position, it may be detrimental. So it's a very, very important precaution. If he is not on an adequate dose of beta blockers, it is going to create a lot of issues, or even a sudden death or VT or VF and whatnot. I think it's very important, and the subject is of a great application in our practice. Let's give a big hand to Hanumanta Reddy for his outstanding presentation.
Ladies and gentlemen, may I invite our chairpersons to kindly step forward and present a medallion and citation in honor of Professor Hanumanta Reddy for having traveled all the way from US to deliver this important lecture on hypertrophic cardiomyopathy. Thank you very much, Professor Reddy. I'd request the chairpersons to kindly stay on.